Hello and good afternoon. This is Mary Marinowski. I'm a medical affairs manager at Nestle Health Science, and I will be moderating today's webinar entitled Nutrition and Pressure Injuries, Putting the New Guidelines into Practice. Financial support for this presentation was provided by Nestle Health Science. The views expressed are those of the presenter and do not necessarily represent Nestle's views. The material is accurate as of the date it was presented and is for educational purposes only and not intended as a substitute for medical advice. So today I am very, very pleased to present today's speaker, Dr. Mary Litchford. Dr. Litchford is an internationally recognized speaker, author, and consultant to healthcare organizations. She is president of Case Software and Books, a professional and educational resource company. Dr. Litchford also served as president of the National Pressure Injury Advisory Panel, NPIAP, from 2017 to 2019, and was a representative on the International Clinical Practice Guidelines Governance Group. Furthermore, she was the sole dietitian and nutritionist on this group. Her most recent publications include Nutrition and Pressure Injuries, Putting the New Guideline into Practice, which is a CE program. And she also has textbook chapters in both Krause's Food and Nutrition Care Process 2020 and another book called Integrative and Functional Medical Nutrition Therapy 2020. Dr. Litchford has received the Excellence in Consultation and Business Practice Award from the Academy for her contributions to translate nutrition science into real-world applications for patients. So welcome, Dr. Litchford. We could not be more honored to have you.
Well, thank you very much. My question to the audience is this: do you feel confident about your role in meeting the nutrition needs of your wound care patients? Now think about this. How would you describe most of the clients you're working with pressure injuries? Are they survivors that are fighting polymorbidities, or are they thrivers with well-managed conditions and healing wounds? Well, today we're going to talk about nutrition and wound healing, and we're going to start with the science of skin and key nutrients that are needed for wound healing. We'll also discuss the nutrition recommendations in the 2019 Prevention and Treatment of Pressure Ulcers/Injuries Clinical Practice Guideline. Now, in the US, we use the term injuries. In Europe, they use the term ulcers still. And in Pan-Pacific, they use the word injuries as well. And then lastly, we're going to apply and practice implementation of the 2019 CPG, that's Clinical Practice Guideline, nutrition recommendations using a case study approach. So let's begin with our content areas. We're going to start with the science of skin and nutrition status. Now, skin is the largest organ in the body. And I want you to look at your arm or your hand. That outer layer of skin is called the epidermis. And it is the thickest layer, or it has 5 layers rather, and it is the thinner layer. The dermis is the thicker layer, but it is the toughest part, and it's got keratin in the cells, and this is a tough and fibrous insoluble protein, and it's going to block most water and oily-based substances. Now, there's no blood vessels in the epidermis. There are 5 layers of the epidermis, but there are no blood vessels. And so it is dependent on the dermis for nutrient delivery and waste removal. Now, everything's got to go through that middle section, which is the basement membrane zone. And you'll notice on the slide where the arrows are pointing to. And we'll talk about it in a minute. Now, the dermis is the thicker part, and that's that lower layer. Now, notice there are 2 parts to the dermis. The dermis has these finger-like projections. You can see those on the image. That's where all the nutrition action occurs. This is where the capillaries are. They're elastic fibers where oxygen and nutrients are exchanged. Now, the bottom part of the dermis is where you see that denser connective tissue, the larger blood vessels. You'll have bundles of collagen and elastin and adipose tissue. Now, the section in between the BMZ, the basement membrane zone, anchors the epidermis to the dermis. Now, if you try and pick up the skin on the top of your hand, for the younger participants, you can hardly pick up any skin at all. But as you get older, you can lift that epidermis up just a little bit, and for some people, even more. Now, that shows you that the junction between the epidermis and the dermis at the basement membrane zone isn't quite as strong as it once was. So that's one of the reasons why people get wrinkles, is because of weakness in that juncture. So why is knowing the science of skin important? Isn't that really a nursing issue or somebody else's job? Well, you know, skin is designed to protect the internal workings of the body. And the epidermis and the dermis layers serve different purposes. But why are these facts important? Well, a while back, I was listening to a Wellness Wednesday podcast, and I listened to a variety of things that are presented by experts and people who aren't experts. Now, this person described herself as a nutrition healer, and she was really just selling cosmetics and nutritional supplements. But I was real interested in what she said. She made the statement that everything that touches your skin enters the bloodstream within 26 seconds. Let me repeat that. Everything that touches your skin enters the bloodstream in 26 seconds. Really? In 26 seconds? Well, we'd all be dead if that were the case. And so understanding that there are no blood vessels in the epidermis is how you know that that fact is not true, or that statement is not a fact. But what about those patch vitamins? We all have clients who have asked, or family members who've asked us about these. They're patch vitamins, patch minerals, and patch protein. And so can you get all these supplements from sticking a patch on your skin? Well, there's really little research about transdermal nutrient delivery systems. Now, we do see some patches with medications, and for oil-based products, like some of our fat-soluble vitamins, particularly vitamin D, we do see some data that shows that you might be able to absorb some vitamin D and maybe vitamin E through the skin, but the water-soluble vitamins aren't absorbed at all, and neither are the minerals, much less protein. That's going to be a much larger molecule. So understanding about the layers of skin is very, very important in how you evaluate products that come on the market. We know that nutrition plays an important role in maintaining skin, whether it's by oral intake or by infusions, but those topical products that are in lotions and in other cosmetic products may make the skin softer, but there's really very little evidence that those nutrients are absorbed into the bloodstream and make a difference in terms of nutritional status. We also know that our lifestyle choices can protect the skin, such as wearing sunscreen. But you really can't counteract your genetic makeup and the footprints of time as it affects your skin. Now, in working with patients and working with families, I think it's very important that we communicate what is the relationship between nutrition status and skin health. And what's the relationship between nutrition status and wound healing? Because I'm not convinced that all of our colleagues and all of our patients and their families really understand what happens to individuals over time, and especially those that develop pressure injuries. This is from a paper that I wrote a number of years ago, and I call it different things, but on our slide today, I've called it the footsteps to undernutrition and malnutrition. When you have a family member who's come from out of town, they're just shocked at what their loved one looks like often. And in 2020, we are seeing families not being able to see their loved ones for periods of time due to the pandemic. And so they're really surprised sometimes at how the person has changed. So I always like to explain this cycle, that it starts with reduced appetite due to a loss of sense of taste and smell, the social isolation. Inflammation is going to increase cytokine release, and that's going to reduce appetite as well. Then the declining functional status, the loss of hearing and vision, the inability to cook and shop. A lot of times there's a loss of the muscles of mastication. So the masseter and the temporalis muscles become weaker and there's impaired chewing. Sometimes there's poor oral health and of course sarcopenia. Then we have impaired nutrient utilization. A lot of times that's related to poor diet, but it can be food medication interactions and a decrease in organ function. And the last piece of the puzzle, of course, is financial. Whether it's limited access to the grocery store or limited dollars for food and medicine. So I always like to explain kind of what has happened to my loved one when I'm working with families to be sure that they really understand why this person's status is the way it is today as it relates to their nutritional status. Now, the macronutrient that is really the driver in wound healing is protein. And let's talk about some basic concepts of protein metabolism. There is less research on protein than on fat and carbohydrate. And so it's kind of the neglected macronutrient. I have a question for you. How much protein does the body process every day? Now that is different from what is the protein requirement, because we all know that the RDA for protein is 0.8 grams per kilo of body weight, and for older adults, we usually recommend a little bit more than that. That's not the question. The question is, how much protein does the body actually process or use every day? Well, the answer to that question is about 250 to 300 or more grams of protein every day is processed in the body. A third of that comes from diet, and 2/3 comes from lean mass. That's what LM stands for. Now, you have lean mass and skeletal muscle as well as organ tissue. But if you're getting enough protein in the diet and enough energy, then you're going to primarily take protein out of skeletal muscle. The body breaks down all the protein into individual amino acids, and those amino acids are reorganized and regrouped to make our dispensable amino acids, the ones the body makes, and makes tissues to repair the body or perhaps for growth for children. There are certain nucleic acids and other components that contain nitrogen that we need the protein for. And so you have this turnover of amino acids, and a little bit is oxidized, but you don't really waste very much, because at the end of the day, every gram of protein that is taken out of lean mass needs to go back into lean mass. Otherwise, you start losing your skeletal muscle. And so every molecule of protein has a job to do. There aren't any reserves that are just stored, unlike fat in the body. So what happens when the diet is very low in protein and low in energy? Say the person consumes maybe 30 grams of protein a day. That means you've got to take more protein out of your lean mass reserves in order to synthesize those dispensable amino acids. And a lot of times there's just not enough protein for growth and repair of tissues. So we see a decrease in rate of those repair processes. We also see an increased use of protein for energy. And lastly, we see at least a 30% or more waste. In other words, the body isn't very efficient. And this is the effect of inflammation and acute injury, is that the protein and energy requirements increase, but because of the cytokine impact on appetite, Many of these individuals have no appetite at all, and they don't eat very well. And so that's why we see increased recommendations or increased requirements for both protein as well as energy. This is the data that Pellet and Young published back in 1992 and in some subsequent publications as well. And what it shows us is that the lower the energy intake, the greater the risk for negative nitrogen balance. Well, if you want to have good wound healing, you've got to be in positive nitrogen balance. And so when you're in negative nitrogen balance, the body is just trying to maintain itself, and usually you have very slow wound healing. So if you are in negative energy balance, your protein requirement is higher. So what is the relationship between nutrition status and skin health? Well, you've got to have enough energy, you've got to have enough protein to maintain the skin. Malnourished individuals can deplete their nutrient reserves pretty quickly. That means that you're going to be breaking down vital organs to get that muscle. And so think about the cardiac muscle. That's one that you need to maintain and retain all of its integrity and not be using that protein for energy, for example. And remember that protein will be burned for fuel if energy intake is insufficient. So now let's talk about wounds and nutrition and healing. So how does nutrition impact wound healing? Now, as a nutrition professional, are you involved on the wound care team? Well, you should be, because nutrition matters in wound care. And so the first step to healing is recognizing that there's a wound. And unfortunately, a lot of dietitians are not involved on the wound care teams. And so they don't always know that individuals are at risk for pressure injuries or they have a pressure injury. So what are wounds? Well, it's any type of an injury to a living tissue. It's caused by a cut or a blow or some other kind of impact. Now, the skin may be broken, but it also can be intact, so you can have a closed wound. It's usually associated with a disruption of structure or function. It may be intentional. Think about radiation therapy. The therapy doesn't intend to cause the wound, it's just a side effect. And same with surgery, that's an intentional wound. Versus an unintentional wound, such as a trauma or an injury or pressure injury. And some wounds are very slow to heal and become chronic wounds. So are wounds really a silent epidemic? Well, if you look at the data from the 2018 analysis of Medicare beneficiaries, what they reported was that there are 8.2 million people that have wounds in the world, in the US rather, with and without infections. And so about 3% of the population, 65 years and older, have open wounds. More than 25% of older adults in long-term care facilities in the US and Canada have pressure injuries. About 2.5 million adults in the US will develop a pressure injury every year, and that costs about $11 billion to treat. That's a number I really have a hard time even getting my mind around as to how much money that actually is. So what is a pressure injury? Well, the Pressure Injury Advisory Panel refined its definition of pressure injuries back in 2016. And so there are basically four areas. A pressure injury is a localized damage to the skin or underlying tissue, usually over a bony prominence or related to a medical or other device. It can be an intact skin or an open ulcer. It may be painful. The injury occurs as a result of intense or prolonged pressure, or pressure in combination with shear. And the tolerance of soft tissue for pressure and shear may be affected by microclimate, nutrition, that was added in 2016, perfusion, comorbidities, and the condition of the soft tissue. Now, there are different stages of wounds, and all of that information is available at the NPIAP website. Now, pressure injuries are considered a hospital-acquired condition, and HRQ has had a national effort to try and reduce these hospital-acquired conditions. And this was a report that came out a year or two ago, and it looked at data from 2014 to 2017. I circled in green pressure ulcers. That was the term they were using at that time. We've seen an increase in pressure ulcers or pressure injuries. Notice all the down arrows, all the other hospital-acquired conditions have either had a decrease or surgical site infections have stayed the same. And so this is an area where we still need to do a lot of work. Now, there are lots of different definitions for stages of pressure injuries. And in the US, we use the stages from the National Pressure Injury Advisory Panel. And so a stage 1 is going to be a non-blanchable erythema of intact skin. A stage 2 is a partial thickness skin loss with exposed dermis. So you're already through the epidermis, you're through the basement membrane zone into the dermis. A stage 3 is a full thickness skin loss. A stage 4 is a full thickness skin and tissue loss. And then there are two others, an unstageable pressure injury, and that means that the wound is covered with slough, or it could be covered with eschar, so we really don't know the stage, and then a deep tissue injury, which is a persistent, non-blanchable, deep red, maroon, or purple coloration, and that's pictured on our slide in the upper left corner. That's a deep tissue injury, and if that epidermis does unroof, then we might have a very deep injury below that. Now, there are two other pressure injuries that are described by etiology, and they are a medical device-related pressure injury, which is the picture on the right. We see these in children more often than in adults, but any type of medical device can cause excess pressure and cause skin breakdown. And then the last one is a mucosal membrane pressure injury. And the definitions are available at npiap.com website. The picture in the lower left-hand corner is probably a stage 4. We can see some a full thickness, looks like a full thickness wound, and some of that white part could be slough. But we have a very serious injury here. So how is nutrition related to risk for pressure injuries? Because we want to look at both risk assessment as well as treating a wound that is present. And these are the nutrition related factors that have been identified in the literature. Increased nutrient needs, undernutrition, malnutrition, dehydration, low BMI, inadequate food and fluid intake, an inability to feed self, a person with multiple risk factors, and certainly someone with an acute injury or who's had major surgeries that are often stress related that are causing hyperglycemia. So when you have poor glycemic control, you usually have very poor wound healing. So let's talk about the nutrients that are involved in wound healing, because all wounds follow basically 4 steps in healing. And if the wound gets stalled in one of these phases, you want to look at the nutrients that are being provided at that stage of wound healing as you revise what your nutrition care plan is. The first stage is homeostasis, and so that's blood clotting. So you're going to need protein and energy for blood clotting and to address that issue, because you always have an immune response. You need vitamin K for blood clotting. Now, if you have individuals on warfarin, Warfarin works by inactivating vitamin K. Now, vitamin K is recycled in the body. It's used about 200 times. And so what warfarin does is it makes it a one use only for vitamin K. And so you can have a vitamin K deficiency in individuals that are on warfarin. With warfarin, we want them to have a consistent amount of vitamin K in the diet. Now, ascorbic acid can also be deficient because with homeostasis, with any type of wounding, the first step, homeostasis, you have an immune response. And that immune response causes a release of white blood cells, neutrophils primarily. And those neutrophils have a very short half-life, and they need ascorbic acid to make more. And so that's why you have that increased requirement for ascorbic acid. The next phase is inflammation, and sometimes we think about inflammation, oh, that's bad, but it is one of the steps in wound healing. And so if you don't ever get to inflammation, you can't heal the wound. So of course, protein energy, ascorbic acid, but also B complex vitamins because of energy metabolism. When you get to proliferation, that's where you're filling in that wound bed, and with a pressure injury, you have an open wound bed, unlike a surgical site where the edges of the wound are pulled together and stitched or glued. And so the cells have to migrate across that wound bed, and so that's going to take a lot of protein, a lot of energy. The studies have identified arginine as being beneficial with proliferation, and this is a conditionally indispensable amino acid, meaning that the body can make arginine, but it can't make enough of it. So it becomes more like an indispensable amino acid that we need to get from the diet. But it's only in situations of inflammatory stress. Vitamins A, C, and E, B complex vitamins, folate, iron, zinc, and copper, and selenium. And this is based on a study, several studies by Dr. Cedra, who is out of Milan, Italy, and that reference is at the bottom. They found better healing with products that were fortified with these nutrients. When you get to the maturation phase, the number of nutrients has decreased. We're down to protein, energy, ascorbic acid, and vitamin A. So how is nutrition status related to wound healing? Well, you've got to have sufficient protein and energy intake for healing. You've got to have sufficient vitamins and minerals for healing. And you always need to look at what kind of medications people are taking, because some medications cause a loss of vitamins and minerals. Certainly alcohol can impair utilization of certain vitamins. And so keep that in mind in terms of risk for micronutrient deficiencies. And certainly polymorbidities may hinder healing. And so the more you have going on medically with the person, sometimes the more difficult it is to heal the wound. So let's talk about our prevention and treatment of pressure injuries from our clinical practice guideline. Well, the guidelines come out every 5 years, and this is what the cover looks like. And the quick reference guide, which is pictured on the left, is available for free download. It just has the recommendations and the good practice statements in it. If you get the full version of the clinical practice guideline, it's very reasonably priced for a download, or you can get a paper copy. These are the websites where you can get the document available to you. The full clinical practice guideline has a summary of all the research as well as implementation guidelines, which are very helpful for practice. So let's talk a little bit about what's in the guideline. This is the strength of evidence, and notice that we've added what are called good practice statements. So we have evaluated the quality of the evidence, and for those statements that are not supported by a body of evidence as listed above, but are really considered significant for clinical practice, or things that are based on expert opinion, these become good practice statements. Now, some of the recommendations in prior editions of the clinical practice guideline were recommendations and now are good practice statements because they were based on expert opinion. And so that doesn't negate the importance of the good practice statements, but this is how the guidelines governance group evaluated the evidence and based on what the international standards are for clinical practice guidelines. We also have strength of recommendation. You definitely do it, probably wouldn't do it, etc. And so you'll see these arrows throughout the guideline for each recommendation. Now, there are fewer recommendations in 2019 than in 2014. There are 10 nutrition recommendations, there are 5 good practice statements, and there are implementation considerations. So some of the recommendations have been merged. Some of them that were based on expert opinion became good practice statements, or they were incorporated into implementation considerations. So let's look at what is out there. The first is on screening, and you'll notice a lot of similarities from the 14 guideline. And so the first one is conducting a nutrition screening, and that needs to be done at admission, and the screening needs to be done by somebody other than the registered dietitian nutritionist. Certainly someone else from your department might do it, or a nurse could do it at admission. There are some screening tools that family members can complete, and it needs to have that data integrated into your electronic medical record. It needs to be done with any significant change of clinical condition or when progress towards pressure injury closure is not observed. Now, I have a couple of slides with all of the validated tools that are listed in the guideline. All of them have unplanned weight loss as a criteria. Some of them have appetite, and then the others have a wide range of criteria listed. And each one has a link, so you can look those up on your own as to how you might use that in your practice. Now, the next criteria is conducting a comprehensive nutrition assessment. Now, in 2014, we gave a lot of examples and elaborated on what was involved in that, but this time it's not as prescriptive. So that really isn't very different. 4.3 is to develop an individualized nutrition care plan for individuals at risk of a pressure injury who are malnourished or at risk of malnutrition. And so that care plan does need to be individualized. It needs to be interdisciplinary. It needs to revolve around the patient's goals and preferences, include due dates, and review and update frequently, are just some of the implementation recommendations here. Now, this is where we're starting to get into some changes. The energy and protein recommendations for individuals at risk for pressure injuries have changed. In the 2014 edition, there were very specific levels of both energy and protein recommended. In 2019, we have a general recommendation of optimized energy intake for individuals at risk of pressure injuries who are malnourished or at risk of malnutrition, and a good practice statement for the protein to adjust protein intake for individuals at risk of pressure injuries who are malnourished or at risk of malnutrition. Now, why is there a change? Well, we certainly have lots of indirect evidence that individuals at risk for pressure injuries with malnutrition benefit from having more energy and more protein in their diets. But there really weren't any high quality research studies to demonstrate that a higher protein and energy intake really reduced the incidence of pressure injuries for individuals at risk. There were also a couple of studies that showed that it didn't make any difference. And so that's why that change was implemented. Now, for individuals at risk, these recommendations are basically the same, 30 to 35 calories per kilo of body weight. That's based on actual body weight. The Clinical Practice Guideline does not address the unique needs of individuals with obesity. And so this is the recommendation. It is based on indirect telemetry data and use of predictive equations. Because indirect telemetry is not available worldwide, that recommendation wasn't put in here to use indirect telemetry. And because the predictive equations require a lot of mathematics, we wanted something that was simpler. And so the recommendation from the small working group was 30 to 35 calories per kilo, as it has been in the past. The protein level remained the same as well. And both of these were B-level recommendations. Now, these recommendations do apply to all stages of pressure injuries, including deep tissue injury and mucosal tissue injury. So what about supplements? Well, there is a recommendation to offer high calorie, high protein, fortified foods or nutritional supplements in addition to the usual diet for adults who are malnourished and who are at risk of pressure injury or who have pressure injuries. And that is a C-level evidence. So that is a lower level of evidence. That was for at risk. This one is for someone with a pressure injury. And so that has not changed either. This is the area that has changed, the 4.10. And that is to provide high calorie, high protein, arginine, zinc, and antioxidant oral nutritional supplements or enteral formula for adults with a category or stage 2 or greater pressure injury who are malnourished or at risk of malnutrition. Now, in the past, the recommendation was stage 3 or stage 4. Now, there is not a specific recommendation to use the high calorie, high protein, arginine, zinc, and antioxidant fortified products for stage 1 deep tissue injury or mucosal tissue pressure injury. So what does the evidence show us? Well, certainly there's a good bit of evidence that is out there for individuals with pressure injuries. For individuals at risk, the research has mixed findings, and so that's why that's not in there. But what we found in all practice settings for individuals with pressure injuries is that giving them these products that are fortified with these extra nutrients, that they did have better wound healing. And even though these products can be more expensive in some settings, it really does save you money in the long run because the length of time it takes to heal that wound is shorter. And I think we have to look at the fact that it's not always just one thing that we need to look at, that we have multidisciplinary problems, and so we have to have a multidisciplinary approach to our wound healing. And then in terms of artificial nutrition, this has become a good practice statement to discuss the benefits and harms of enteral and parenteral feeding and to support overall health in light of preferences and goals of care with individuals at risk of pressure injuries who can't meet their nutritional requirements through oral intake despite any nutrition intervention that we have. And then for individuals with pressure injuries to discuss the benefits and harm of enteral or parenteral feeding to support pressure injury treatment in light of preferences, goals of care for individuals who can't meet those nutrition requirements despite nutrition interventions. So how are we going to summarize this? Well, the CPG has higher quality research in it in 2019 than it did in 2014 because there's a lot more research. There's a lot more work to be done. There are fewer recommendations, and the good practice statements include expert opinion or limited or inconclusive evidence. The implementation considerations are very valuable to provide guidance to translate recommendations into practice. And all those things apply to the nutrition chapter, that there are fewer recommendations, there are specific energy and protein requirements for prevention, but they're very general. They're not as specific. So that's 4.5 and 4.6. And then the disease-specific oral nutrition supplement for individuals with stage 2 or higher pressure injury, 4.10. So those are the three areas where there are changes. So let's look at a case study and see about applying this information. This is Lee, and the neighbors have noticed that Lee hasn't walked her dog in several days. She usually walks her dog early in the morning. She's a retired teacher, and she's fiercely independent. She has no family living in the area, and she's never married. She has no children. The pharmacy delivery driver notices boxes on her porch. The driver suspects something is wrong and can hear a faint cry in the background. And so, with some discussion with the neighbors, they decide to call the emergency responders. Those folks find that Lee is unable to get out of her vintage-style bathtub. She has no idea how long she's been in that tub, and she's sent to the hospital. She's confused and anxious, and she's moaning in pain. Is she going to be at risk for a pressure injury? Well, she's 76, she's 62 inches tall. Her usual weight from the electronic medical record reports 170 pounds, but her admission weight is 163. She still has a BMI and class 1 obesity. She has a health history of type 2 diabetes, dyslipidemia, GERD, hypertension. She's on a variety of medications, and she has some pressure injuries, an open area on the sacrum, a deep maroon area on the left lateral ankle and the heel. So what does she eat? Well, she mainly eats fruits and vegetables and legumes and grain products. She eats chicken and fish or eggs 3 or 4 times a week, has no problems chewing or swallowing, and no, she doesn't follow a therapeutic diet despite her diagnoses. If you look at her estimated intake, she consumes around 1,000 calories a day and maybe 40 to 50 grams of protein per day. If you look at your Mifflin St. Jaffor estimate, she would need more than that, 1,500 to 1,800 calories. If you look at the RDA for protein, it's going to be about 63 grams based on her usual weight. If you look at 1.0, that's going to be 78 grams of protein. But what are the CPG recommendations? Well, because she does have pressure injuries, you're looking at over 2,300 to 2,730 calories per day. So many, many more calories than what she's currently consuming. And then a range of protein of 98 grams to 117 grams of protein per day. Now, remember that when we're looking at these recommendations, these give you some ballpark figures. And so you don't have to follow these to the letter, and you always have to look at what other polymorbidities the person may have. So let's look at some labs. And so the question is, do you see any signs of undernutrition or malnutrition? Any potential micronutrient deficiencies? And is she at risk for poor wound healing? And I'll give you just a few seconds to look over that information. If we were together face to face, we could have a discussion about this. So here's my assessment. Well, her weight is down. She does have a BMI of 30. She probably has dehydration. Her blood pressure is down, her heart rate is up, serum sodium's high, chloride's high, glucose is high, but it's not fasting. BUN is elevated, albumin's higher than we would expect. And so she has a lot of evidence of dehydration, not to mention the circumstances in which the emergency folks found her. She does have an elevated creatinine, so we'd want to look at the renal status. Some of that may be related to stress, and especially if she's been in the tub for a while. If we look at her iron status, her hemoglobin and hematocrit are low, which is actually kind of surprising because of the dehydration, but her MCV is elevated. And so that suggests a nutritional anemia. She was unable to get out of the tub, and so that says something about her muscle function. And because of her weight, she may have some sarcopenic obesity. And is she at risk for poor wound healing? Well, I'd say yes. She certainly has poorly controlled diabetes with that A1C of 8.5. And so we've got some red flags here. So let's look at her NFPE. We certainly have evidence of the dehydration. We have several pressure injuries that have been noted. We also find that her muscles of mastication are weak, and so that's going to impact the texture of the foods that she can eat, and that she really needs to eat. She is eating chopped foods and ground meat, so she might not be able to eat just the regular diet. Her grip strength on her right and left hand are markedly reduced, and so she has lost some strength, which is going to relate to her nutritional status. And she's had a number of falls, but she hasn't needed assistance getting up. And so what are our goals for care for Lee? Well, we certainly want to do a team approach. We know that successful treatment involves multiple factors. And so just as we need multidisciplinary teams to treat wounds, we can't expect to address just one element of wound healing and expect the wound to heal, and especially if it becomes a chronic wound. And so there's really not a silver bullet out there that is just one individual product or one technology, but it's going to be a combination of interventions that deployed at the right time that will help Lee manage her chronic disease, address her hydration status, and to promote the healing of those pressure injuries, as well as reduce the risk of additional pressure injuries forming. We'd want her to have increased protein intake as well as energy intake in the diet. We would want to consider those high energy, high protein oral nutritional supplements with arginine, zinc, and antioxidants because of the multiple wounds that she has. So let's take a few questions. Our time is rapidly getting away from us, and I will turn it back over to our host to tell me what questions we have.
Thank you so much, Dr. Litchford, for that excellent presentation and very timely one. I think the case study really helped to bring the guidelines to life. There are quite a few questions about the time in which someone with a stage 2 or greater pressure injury should receive, as per your assessment, the specialized ingredients. You know, you mentioned the arginine and the micronutrients and such. Is there a length of time that that intervention should have shown to make a difference, or is there a general length of time from the studies that was required to close those wounds?
That's a very good question. It's going to be, how long are you going to give these oral nutritional supplements? The CEDRA studies had them receiving them for several months. Some of the studies where they didn't show any improvement with prevention of pressure injuries had them receiving supplements for just 2 weeks. And so I don't know there is a hard and fast recommendation for that. And there is no specific recommendation in the clinical practice guideline because it is going to be based on individual assessment and how quickly that wound heals. Now, in a person such as Lee, we've got a number of polymorbidities. We've got diabetes that doesn't appear to be well controlled. We have blood pressure issues. And so we've got to get her other issues under control, and we need to address that as well as the wound healing. So got a lot of things to deal with. And so it's going to be based on individual assessment. But she's going to need to be on the supplements probably longer than 2 weeks. Now, my recommendation for my own practice is that if you find that after a month or several weeks, you are not having the outcome that you expect, sometimes you need to regroup. And so if the person's been on the supplement for at least a month, and you're finding that you're not seeing improvement, then you would want to relook at all aspects of care. And so is it an issue of not getting enough of your indispensable amino acids? Remember that her diet was primarily a plant-based diet, and so she might not be getting sufficient amounts of some of our key indispensable amino acids, specifically methionine and leucine. And so if you're not getting enough of those, then you're not going to have a strong wound healing. And so you've got to just step back and look at what is the issue and how can we better address it. And sometimes it's digging deeper into their diet as to what key nutrients might be missing. The other is to look at, are her medications promoting loss of nutrients or micronutrient deficiencies, and would the person benefit from supplemental nutrients? Now, there's not a recommendation for a vitamin mineral supplement. And so again, that's going to be based on individualized assessment. Most of us don't have access for a lot of labs to look at individual nutrients, but you can look at which medications are associated with certain nutrient deficiencies.
Thank you for that. Okay, and Dr. Litchford, you mentioned that with the NPIAP guidelines, the latest edition that you covered today, that the calorie and protein amounts that are advised are per actual body weight, and that they don't go into an explanation as to how to adjust that or whether or not to adjust it in the patient who would be morbidly obese. Do you have some recommendations just from your own practice as to how you would manage the person with, let's say a BMI of 35 or 40?
I served on the bariatric small working group. And so they use the term bariatric to mean the patient with obesity or the adult with obesity. And we searched the literature and found no studies to use that gave us any information about what would be appropriate in terms of energy or protein. That is always going to be based on individual assessment. My personal experience is that these individuals that have pressure injuries often consume at least or more 30 to 35 calories per kilo, and the protein can vary, and so sometimes we need to increase that. So you've always just got to look at where are we starting, and if we increase it, what is reasonable to do for that particular person. And so I don't have a good answer for that because there is no literature out there to support any type of recommendation. It's all based on your own clinical judgment. And so look at where the person is, look at the quality of the diet. And again, if you'll look at the amino acid profile of the protein products they're consuming, and you look at the indispensable amino acids most likely to be limiting, which is going to be methionine, threonine, tryptophan, and cysteine. And then leucine would be the next one I'd want to look at, because leucine is the amino acid that you've got to have sufficient levels of to start muscle tissue synthesis. And you got to get that from good quality protein. And sometimes people can consume the level of protein that's recommended or higher and the level of energy or higher, but if they're not getting all those micronutrients or those amino acids that they need, then you're not going to have good wound healing. And there are RDAs for all of our indispensable amino acids. So for an individual with obesity who had very poor wound healing and what we were doing wasn't working, I would kind of go back to the basics and look at the RDAs for those amino acids and look at what they're eating and see how we could modify their diet based on that.
Thank you. We are running short of time, but I want to make sure to take this first question that came in, and I think it's really a good one because of the way that referrals are made. This individual finds that they are referred, they receive a referral to see a wound patient, but that it's dependent on the Braden scale screening that the nurses are doing. And I know there is a nutrition component to the Braden scale screen, but what are your thoughts on our dietitian referrals being dependent on that process?
Well, the Braden scale does have a nutrition component, and it is recognized as a validated tool for nursing. But the nutrition subscore is not a validated tool. And so if they are using just that as their criteria, then they're not following the clinical practice guideline because the subscore is not a validated tool. You need to use one of those validated tools on the list that I gave you, and that it really needs to be based on that because that's really no different than your organization just deciding that they're going to follow these criteria, and you have a tool that was developed in-house, but it wasn't validated. And the recommendation in the clinical practice guideline is to use a validated tool.
Okay, I think that's extremely helpful. And I just want to thank you, Dr. Litchford, so much and for everyone's attention today. So on behalf of the Nestle Nutrition Institute, we hope you found this information useful to your practice. Please enjoy the rest of your day and stay safe and strong. Thank you.